It's my pleasure to introduce our first set of speakers, Dylan Morris and Simon Levin. I don't think so anybody needs, to have an introduction for Simon, but even so, I can say that Simon is just a world-renowned ecologist, epidemiologist, and who's been so kind to work with us on this project for a long number of years now. And Dylan is his PhD student and has done some very cool work. Actually, I heard this talk that they gave in one of the student meetings that Simon organizes, and I found it very interesting. So this is a joint work with Dylan, Fernando, Josh Plotkin, and Simon, and I'm going to let Simon take it from here. But thank you very much for taking the time and doing the first talk. So go ahead, please.
First of all, it's our pleasure and honor to be able to be working with Madhav, who's been a great leader for this project. And my job mainly is going to be to introduce Dylan, who has really been the leader, along with Fernando Racine, another graduate student on this project. And I'm just going to talk for a few minutes, 6 or 7, to set things up. Obviously, the solutions to infectious diseases, like you see on the left there, don't work so well today since we don't have easy access to toilet paper. I also want to thank, and that's what we're going to focus on today, I want to thank the various funding agencies that have funded our work. So wherever we turn, we hear about models and COVID-19, and papers on the topic are proliferating, and that intrigued my economist colleague Avinash Dixit so much. He wrote a paper on not for COVID, but for papers on COVID. And he said, if any pandemic is spreading faster than COVID, it's that of research about it. So he made some estimates of what R0 is, and I can provide documentation to this because on the editorial board of the PNAS, we're getting buried in papers. So it's important to understand exactly which of these models to begin, what's in the black boxes, how good are the models, what are their limitations, and for what purposes are they most effective. This is sort of the standard model that people are using, slight variants on it. The population's broken into susceptible, infected, infectious, and removed. And there's slight variations in that one might have a pre-infectious stage or a set of people who will never be symptomatic. And therefore, there are a number of problems we have to deal with. One of them is that there are a large number of asymptomatic infections, and you've all seen not only evidence of that, but you saw the uproar when the WHO authority gave misleading information a few days ago and had to retract it, and Tony Fauci pointed out the problems. But we have to account for asymptomatic infections. We have to account for age specificity because COVID-19, as you know, is having dramatic effects on older individuals and much less so on younger individuals. We need to deal with the coupling and asymmetry. Different areas of the country are opening up, and so the disease gets damped down one place. This is actually my colleague Brian Grenfell's work on measles. There isn't work like this yet on COVID, at least not to the same extent. But how do we deal with the coupling among different areas and estimating the effects of interventions? And as you see in this slide, and as Dylan will develop, what one's really concerned about is the peak, the maximum number of cases. Of course, you're also interested in the total number of cases, but what you don't want to do is to overwhelm the healthcare system. So these are all problems that need to be dealt with. There are a lot of uncertainties in modeling. What percent of the infections are asymptomatic? How infectious are they? We still don't have good information on that. Are individuals who are getting the disease and recovering acquiring immunity? We don't even know if they're getting antibodies, but if they're getting antibodies, does this provide them for protection? And protection for how long? Will the virus evolve? And will we need to keep coming up once we have a vaccine with new vaccines year after year? What are we going to do about vaccine hesitancy? We're seeing increasing numbers of that having to deal with measles and other diseases. But there's some evidence that even once a COVID-19 vaccine is broadly available, large portions of the people won't take it. What are the economic trade-offs, and how do we restart the economy? So in the face of all of these uncertainties, modeling when we might and how we might relax social distancing, quarantining, et cetera, is unclear. Social distancing obviously was essential, but the exact timing of social distancing, as Dylan's going to tell you, that would produce optimal results is not possible. There was an article a few weeks ago in the New York Times, largely coming out of the Columbia group, showing that we didn't time things right. We didn't get in front of this. Everybody knows this quickly enough, and we could have saved a lot of lives had we done so. So what prompted, I think, a lot of our interest, especially Dylan's interest in this problem, is that the original British model that was proposed frightened everybody, would have been disastrous. The Swedish model has not worked well. I just was looking at the numbers. It's true that the Swedish population has a large number of older individuals, but the death rate in Sweden has been 10 times the death rate in Norway, and the average age in the population is approximately the same. So although some have argued that we still don't know the answer to whether Sweden's herd immunity experiment works, I think it has clearly backfired. And so going forward, obviously we can't live in a lockdown stage forever, but willy-nilly relaxation will be a very dangerous thing to do. And of course, we're seeing a lot of this around the country already with the pressure to open early. We will eventually return to something closer to normalcy, but we have to do so wisely. And that's going to involve some perhaps staggered release policies. And in all of that, we're going to need to rely on testing and contact tracing. But even with effective testing and contact tracing, there's going to be a delay in getting the information that we need, and there are going to be errors. So there are lots of challenges, which is what motivated the paper that Dylan and Fernando Racine, whose picture you see underneath Dylan, led, and involving Joshua Plotkin and me. And I'm going to turn things over to Dylan now to discuss in detail the work we've been doing on what would be robust epidemic control policies and release policies. So Dylan, it's all yours.
Thanks for that introduction, Simon, and thank you all for having me. And I'll try to take you through a bit of what we've been trying to do to think about exactly how Britain and Sweden got it wrong and how we might get it more right, and the US got it wrong, going forward. So, as Simon said, flattening the curve has entered the popular lexicon. This idea that one of the important things to do in controlling an epidemic is to minimize the number of cases. But particularly if you can't stop the epidemic from propagating altogether, the way New Zealand did, Australia may be able to do, Vietnam did. But if you're more in the situation of a Germany, you may not be able to stop the epidemic from propagating, but you'd love to slow it down so that you don't overwhelm your healthcare system. Because at any given time, if you have a slower, flatter epidemic, not only will you get fewer cases total. This is a common misconception that flattening the curve does not reduce the area under the curve. It absolutely does reduce the area under the curve. But on top of that, it also dramatically reduces the social economic costs and reduces the actual mortality from the disease, simply because it is a lot easier to handle a small number of cases at any moment in time than to handle things when you have a sudden spike that overwhelms your healthcare system, probably overwhelms your supply chains, and in general causes higher rates of death and greater social disruption. And yet, while there are great costs to overwhelming your healthcare system, there are also great costs to taking the kind of control measures that we have in our arsenal prior to having antivirals or a vaccine. These non-pharmaceutical interventions, like physical distancing, have, for example, intense economic costs. One of the scariest graphs I've seen in COVID is this graph from the New York Times, where we see a time series of American unemployment claims from US official statistics, and you barely can fit one of the weeks after the shutdown in the US on the plot. It's just this ginormous spike that we see here. And of course, disproportionately hits people in precarious jobs, people who have lower income to begin with, probably little wealth, and in a country without a strong social safety net like the United States. That cost is intensified and can even result in death. And so people were concerned about the costs of maintaining non-pharmaceutical control indefinitely. And people also feared second peaks after the relaxation of non-pharmaceutical control. Because if you hammer the virus early, very few people will develop immunity. And if you relax controls before there's a vaccine, the epidemic, if not eliminated entirely, will propagate again. And if you're New Zealand, maybe you can have sufficient quarantines at your border that you're going to be able to stop reintroductions. But a lot of people in big countries that are not islands, like the United States, were concerned that A, it wouldn't be possible to eliminate the epidemic entirely, and B, even given elimination, that reintroductions from elsewhere would simply seed a second wave. And so there was a lot of concern that social distancing was dishonest, that it just pushed infections into the future. Now, as I said to you earlier, this was to some degree a misconception about epidemiological models, because in fact, some infections are pushed into the future while others are averted entirely. And what's more, it is actually easier to deal with infections in the future than infections in the present. By the time we reach the future, we may have better testing and tracing. We may have antivirals. We may be closer to a vaccine. So this idea that a first wave and a second wave are equally scary, I think, was itself something of a misconception. And people's fear of second peaks was a little bit misguided and sort of came from anchoring too strongly on the 1918 flu. That said, there was a legitimate fear here that if you shut down too soon and too aggressively and then reopened entirely, you just have a big spike later rather than a big spike earlier. And the UK government in particular was very concerned about these second peaks. In an interview in mid-March, Deputy Chief Medical Officer Jenny Harries, pictured here, said, if we put our distancing in too early, we'll just pop up with another epidemic peak later on. And so the Brits really wanted to wait and try to time it so that their intervention would prevent their healthcare system from being overwhelmed, but not produce these feared second peaks. And yet, I and a lot of other people were concerned that what if you get this timing wrong? What if you are a little bit late or indeed a little bit early? How bad is it going to be if you're trying to just optimize this thing perfectly so that you get the maximum reduction at the peak in the minimum cost? Is this actually going to work? Will it be robust to the kinds of implementation errors that are inevitable in real-world policymaking and real-world policy implementation? And so I voiced these concerns on Twitter in a thread that went semi-viral. And I got, Brits can be quite passive-aggressive. I got some passive-aggressive comments from British mathematical modelers. They said, well, this works very well as a verbal argument, but would it stand up to scrutiny as a mathematical model? And being, as I am, not especially passive-aggressive and more of a sort of chip on his shoulder, in-your-face American, I said, well, you want a mathematical model? You're going to get a mathematical model. And so in collaboration with Fernando and with Josh and Simon, I sat down to say, let's try to make not a straw man, but a steel man version of the British strategy. Let's try to come up with an optimal curve flattening. If you had a limited amount of time and wanted to nail this as best you could, get the maximum reduction at the minimum degree of social cost, what would you do? And then, given this sort of perfect strategy, doing the best you can do, how robust would that be? And so that's what we sat down to do, and I'll show you what we came up with. Our approach was to try to be as simple as possible so that any lack of robustness we found couldn't be attributed to some detail of the model, but was really sort of a more fundamental property of these epidemic systems. So we just took the classic susceptible infectious recovered model, which many of you have seen. Susceptible individuals who can get the disease are infected at a rate beta SI, where S is the frequency of susceptibles and I is the frequency of infectious, and beta governs the contact rate between these two classes. These individuals then recover at a rate gamma, per capita rate gamma. They move into a recovered class. And to be extremely generous to these herd immunity strategies that the Brits and the Swedes took, we're going to assume that everyone who recovers remains immune, at least for the duration of the epidemic of interest. And then we're going to say, okay, these non-pharmaceutical interventions, these distancing interventions, are going to reduce the transmission rate for some duration of intervention tau. And so what we do is we define a function v of t. That's our intervention function. It's 1 before the time of intervention, ti. And then for a duration tau, it's some number less than 1 or equal to 1. Our policymaker can choose how much to reduce the contact rate during that time of intervention tau. But then after t at sub I plus tau, people are sick of the distancing. They get sort of behavioral fatigue, which the Brits were very worried about. They start going back to the beach, as in that picture Simon showed you. The Jersey Shore here in New Jersey is starting to fill up again. And so we assume that the policymaker really only gets this time window from T sub I to T sub I plus tau to intervene and reduce contact. And we then say, okay, given this, can we come up with an optimal intervention that, given your permitted duration tau, which sort of rolls in all the economic costs of intervention, all these things of people getting sick of them, is there an optimal choice of this function B of t? And it turns out we can prove that there is. What it turns out you want to do is first maintain and then suppress. That is, first you choose B of t such that the R effective of the disease, the number of new cases that each infectious individual causes on average, is exactly 1. So each infectious individual exactly replaces themselves, and the disease kind of flatlines, as you can see in these green curves here. The black dotted line shows you what would happen in the absence of intervention. And here we show optimal interventions of duration 14 days, 28 days, and 56 days. And as you can see in each case, the first thing we do is we make the disease flatline. We do that by choosing B of t equal to gamma over beta s, which just says, okay, this is going to exactly equalize the new infections with the recoveries, and we flatline the current prevalence. Now, why would you want to do that? Well, the reason you would want to do that is that this way you are depleting susceptible individuals by allowing new infections to happen, but you're depleting them without allowing the overall prevalence to grow. So you're essentially eliminating the fuel for this epidemic fire without allowing the flames to burn brighter. And you will notice, if we look at the actual plot of B of t, that means you start very aggressively and then you gradually ease off. And the reason you're easing off is that throughout this time, susceptibles are being depleted. So the amount of intervention that keeps the balance between new infections and recoveries equal will become lighter and lighter over the course of this maintain phase. But if the fire needs fuel, it also needs flames, and infectious individuals are the flames. So at a certain point, it becomes optimal to switch from your maintain phase to a full suppression phase, where you set B to 0. In other words, you essentially make a very strict quarantine where you get it as close as possible to each infectious individual, not infecting anybody else. And the reason you want to do that is that now you sort of eliminated fuel, but when you relax your controls, the flames are going to cause growth on whatever fuel is left. And so now you want to sort of put out the fire as best you can and knock the epidemic down so it has to grow again. And the beauty of doing this is that by knocking it down after you relax controls, it is going to grow again to a second peak. But on the way to that second peak, it's going to continue depleting susceptibles. So that second peak will be of limited height, and then it's going to eventually burn itself out, even though you're no longer doing anything. So what we see here is that an optimal intervention uses the two fundamental materials of non-pharmaceutical disease control, susceptible depletion and infectious depletion. And in a way that sort of is maybe not surprising if we think of the principles of economic optimization, it's always better to focus on exactly one of them. You never do a compromise. You're either all in on susceptible depletion with your maintain phase, or you're all in on infectious depletion with your suppress phase. But let's also note, like, if we look at this graph of B of t, this is an impossible intervention in practice. First, you have to perfectly tune your level of intervention in continuous time to keep this maintain phase. And then you have to transition immediately to this aggressive suppress phase. So the next thing we wanted to know is, how well can you do with something a little more realistic? And we found that actually more realistic interventions do almost as well. We studied in blue here these fixed control interventions, where you just choose a level of reduction, B, and you, given your time of intervention, you choose the optimal level of reduction, which might be anywhere from 1 to 0, and you choose the time of intervention. And you'll see that these, for a given tau, reduce the peak almost as well as our much fancier optimal intervention. You can see that the blue curves are only a little bit higher than their corresponding green curves. And moreover, you can see that actually they kind of mimic the shape of the optimal intervention. By choosing the intervention time well enough, you get something that almost looks like a maintain suppress, just a slightly curvier version. And then there's the dumbest possible strategy that still actually works kind of well, which is just say, okay, we're just going to do a very strict quarantine for as long as we can. And even that, it's less good than an optimal fixed control and less good than a truly optimal strategy. But it still achieves a pretty dramatic reduction relative to the unmitigated epidemic in the peak. And the reason that that is true is what I said earlier, that just knocking it down and then forcing it to grow up again forces it to deplete fuel as the flames try to grow high again. And eventually it's going to burn itself out. So we've seen that actually suppression doesn't just push infections into the future, but by forcing the epidemic to grow again, it actually eliminates infections that would have otherwise have happened. And we've seen that even fairly coarse interventions, if they are timed well, can do almost as well as the optimal intervention. And in fact, if you don't have a lot of time to intervene, you just want to hammer it. As we can see two things here as we plot the overall peak as a function of our duration, tau, of intervention. The first thing we see is that eventually the full suppression intervention asymptotes. And we see that, however, the optimal intervention is only slightly better in green than the fixed intervention in blue for any duration. That the fixed intervention, if you optimize it perfectly, does great. And then finally, we see that for very short interventions, they all converge, and this is indeed provable. Below this dotted red line, they all converge to full suppression. So at a certain point, if you have a limited intervention, you just suppress, you don't even bother maintaining. And then one final detail I want to point out to you before we transition talking about robustness that I think is a helpful piece of intuition is that you can also prove for all of these interventions what we call a twin peaks theorem, that under an optimized intervention, whether it's the fully optimal one or an optimized fixed control or an optimized full suppression, you'll notice that there's a during intervention peak that is exactly equal to the post-intervention peak. See that these two green peaks are equal, these two blue peaks are equal, and these red peaks are equal. That is in fact provably true. And again, while it might seem counterintuitive at first, there's actually a very clear explanation. You're essentially trading off infections now against infections in the future. And if you have more infections now, you could do better by allowing more infections in the future. If you have more infections in the future, you could do better by allowing more infections now. So again, we see that actually studying this in a simple analytical framework reveals a mistake that a lot of these policymakers who worried too much about second peaks were making. They sort of saw second peaks as a sign of policy failure. In fact, if you have no second peak, that's a sign that you permitted far too high a first peak. And yet, for all of these optimal interventions or optimized interventions, timing is everything. And the Brits did understand this. And they said, Jenny Harry said, because we have such brilliant modelers, we're confident that we will know the right point to intervene. We're going to time our intervention perfectly. And I was a bit skeptical. And I said, okay, what if you don't? And the answer is you have a disaster. Here's what happens with our optimized intervention. If you time it perfectly, you can see that green curve from before. But what if you are either a week early or a week late? Now, if you're a week early, you have a high second peak, much higher than you would have had if you'd optimally timed things. But at the very least, it happens later. Maybe you have time to build healthcare capacity, develop drugs, and prepare. And maybe as you start to climb up that second peak, you think, oh, we intervened too soon, and maybe you can summon enough political will to have a second intervention. But if you're too late, you have an absolute disaster. You immediately spike up and achieve a very high, higher even than the early peak, first peak. And yes, eventually your intervention comes in and you come down off that peak. You don't really have a second peak, but you've had this high, unmitigated first peak simply by being even a week late in bringing in your optimized policy. And it's identical, in fact, even worse for the more realistic interventions. You can see that the week late peaks for the blue and the red are extremely close, especially in the red case, to an unmitigated epidemic. So being even a week late is disastrous. So one thing we looked at then is, okay, what if you brought in some sustained lighter intervention over the whole course of the epidemic, where instead of trying to get it exactly right, you said, okay, we're not going to be able to reduce R0 as much as we would like, but if you could reduce it even a little, what would that buy you? The first thing that would buy you is that you'll notice this gray curve, sustained control only, does reduce the peak relative to the unmitigated peak that we had here. But secondly, if you then layer on an optimized intervention, you'll notice that whether it's a week early or a week late matters a lot less. Now, why is that? Our lack of robustness before came from the steepness of the exponential growth curve at this point of optimal intervention, T sub I. You can see that the epidemic is growing super fast here. So even a week's difference in timing gives you a huge difference in the state of the world, namely the number of currently infectious individuals. If we've slowed things down even a little, that curve that we're trying to time, that exponential curve that we're trying to time, is much less steep. And so the costs of mistiming for our optimized intervention are much reduced. So if you're going to try some kind of optimized thing, you really should be layering it on top of some lighter interventions that at least slow things down enough so that if you screw up, it's not going to be as disastrous. And this same principle of sustained control applies equally to our more realistic interventions, as you can see here. Again, the costs of mistiming, being a week early or a week late, are much reduced if we've slowed things down a bit with light intervention. And we can study this just by looking at the epidemic peak as a function of how early or late we are. And here we have in gray the epidemic peak in the presence of sustained control. Here in black, the epidemic peak with no intervention. In green, the epidemic peak layering an optimized intervention on top of no intervention. And in dotted green, the epidemic peak layering an optimized intervention on top of sustained control. Now we see two things. First of all, you can see why this optimized hit it once with the perfect hammer was so tempting to the Brits. Because if you really nail your optimized intervention, you do way better than sustained control on its own. And you don't even do that much better than sustained control plus an optimized intervention. So why bother with the sustained control? You swallow the one bitter pill of this optimized intervention and you're done with your mitigation. It's perfect. The problem is if you're not so perfect, because within 4 days of mistiming in either direction, you're already doing worse than sustained control alone. Within a week, you're doing much worse. And if you're 2 weeks off, you might as well not have done anything at all. There's an asymmetry. While it's bad to be early, it is catastrophic to be late. And here we see the benefits of sustained control, because not only is it much more robust, it doesn't matter how you time it itself, but if you then layer something that is timed on top of it, you can see that the steepness in the mistiming is much reduced. We lose a lot less from mistiming in either direction when we're trying to time something slower. And in particular, you can see that even then, being early is a lot less costly than being late. And that's before we account for all the other ways why it might be better to be early, like the fact that being early buys time and mitigating that second peak might be easier because you've built healthcare capacity or you've developed new drugs. So with that, even from this very simple model, I think we have some pretty clear conclusions for policymakers. Principle 1, act early. It is better to be early than to be late, no matter what you're doing. Principle 2, slow things down. The more you can slow down the early propagation of the epidemic, the more any fancier strategies you're going to try. You bought time to really learn about the epidemic, and the more any precise timing you're going to attempt is going to be robust versus deeply fragile. And finally, we saw that the crude strategy of full suppression works pretty darn well. And in particular, it's the best thing to do once you're late. So if all seems lost, just bear down. While New York made a lot of errors in the early going, it did not act early and it did not slow things down. The one thing they did do right was they bore down once they saw that they were in crisis, and that will have saved a lot of lives. So what I hope I've shown you here is that even a very simple analytically tractable model has some real world policy insight to give. And in fact, it gives some policy insight that the more complicated simulation models often miss. Like that a second peak is not necessarily and intrinsically a bad thing. And like that, however tempting an optimized intervention that prevents a big second peak might seem, if you mistime it or poorly implement it, it's going to be extremely fragile. And so with that, I'd like to thank my collaborators, Fernando, Josh, and Simon. I'd like to thank all of you for listening. We have a preprint up that you can look at on the archive. I will also add this link to the Zoom chat. And with that, I'd be happy to take any questions. Thanks very much.
So this is a wonderful talk, Dylan and Simon. So we'll open the floor for questions. This is the first time we've done it. So we'll see whether we can try to do it asynchronously where people ask questions and do not have in what wireless networks would call a packet collision. And we do an exponential back off to maybe do that. So Jeff's hand is up. Jeff, you should go first.
Okay, great.
That might be a good way to do it. Thanks.
Dylan, that was really interesting. I really enjoyed the talk. I was just wondering if you could connect this to a verbal argument that I've seen thrown around, much like your first Twitter announcement, which I think has a very close connection to it. And I just wonder if you could divulge, in your opinion, how close the connection is and how it connects. And that verbal argument is, of course, that when an epidemic is rising, we would like to reach herd immunity. But if it's rising exponentially, it's going to the frequency of the disease will overshoot herd immunity. And you just didn't use that verbology, and I just hope that you could explain how that relates to your results in a more explicit fashion.
Yeah, absolutely. It relates in two important ways. The first is that the overshoot that you're talking about, it necessarily happens unless you cross the herd immunity threshold with 0 infectious individuals. But however much hotter than that you cross the threshold, you'll of course have more overshoot. And so there are two interesting connections there. The first is that one of the benefits of these optimized interventions is that during that permitted post-intervention peak, you cross the herd immunity threshold a lot colder than you would cross it in an unmitigated case. So while these things are mostly targeted at reducing the peak, they do also go a long way to reducing the final size and the total number of cases, that is. The second connection there, I think, that is very important is this problem of over-optimizing. Because while we're studying peak reduction here, I think a lot of people concerned about overshoot had this idea that maybe as you're getting close to the herd immunity threshold, you can just have a strict quarantine there, and then you'll maximally reduce the overshoot. And again, that sounds really great in theory, but I think a lot of the same principles we're talking about here are going to apply there as well, which is that that's really great in theory, but if you mistime that, you're going to lose a lot of the efficacy. Now, because at the herd immunity threshold, things are starting to slow down and you're no longer in the steep part of the exponential, it's going to be more robust than these optimized peak reduction interventions. This optimized final size reduction intervention, you're intervening at a time when things are changing a little more slowly. But even then, I would be skeptical that that would really work. And I would be much more in favor of a slightly more costly, but substantially more robust thing, where you essentially are intervening strongly and you sort of ease off as you start to approach the herd immunity threshold and kind of try to plateau things. You sort of come to a slow stop by easing back your social distancing as you approach the herd immunity threshold. Whether that's going to be possible in practice for something like COVID, where we've already knocked things down and people are pretty sick of things, and we're maybe going to approach the herd immunity threshold relatively hot without much tolerance for additional distancing, remains to be seen. But I think that that would be, in an ideal world at least, the more sensible strategy, where you try to sort of slowly back off and try to bring the epidemic to a slow stop as you approach that herd immunity threshold.
Dylan, that was excellent. It was really good. And in fact, a lot of questions that I had about this and I just haven't had time to really delve into, but brilliant presentation. So 3 things. First of all, actually just go back to Simon. Simon, when you talk to the Swedes, and I'm sure you talk to Swedes all the time because you know them well, they didn't have a lockdown, but for the Swedes, just a gentle nudge saying, it's not a good idea to go out is enough of, that's like a lockdown for them. All the Swedes that I talk to, they're all sitting at home and they're not going out anywhere because the public health agency has told them not to go out. So I think we're making a big deal of the Swedes having a different model. I don't know if they necessarily have a different model. They did have a lack of control on the deaths in the nursing homes, which does happen in various places. But I don't know if that was necessarily a lockdown issue. But then again, the Swedes don't cross a red light for a pedestrian walk, even if it's the middle of the night. They're just that kind of people. So it takes a lockdown for the rest of us unruly people, and all that it takes is a nudge for the Swedes. Second, Dylan, on your model, one question I have is, nothing to take away from your model. I think it's perfect as it is. I think it'll be a great paper. One thing that the second peaks or the delayed infections do, the rationale for the lockdown or for social distancing in many developing countries, and if you read about this, you'll see, it wasn't just about the optimization. It was also about the fact that they were just plain unready for any sort of epidemic. They didn't have the ICU beds, they didn't have the capacity, and it was really to buy time. And that's something which maybe is missing in your model. It could just be like a supplementary materials or something. But I think that's an important rationale for why people didn't want to face it in the first round and said, look, give me 3 months or 2 months, I'll get the hospital beds ready and then I'll deal with it. Associated with that is also the fact that I think everyday medical knowledge, particularly on how to take care of patients clinically, is improving. All this prone position, how to ventilate, all this stuff. So I think that your chance of survival is actually improving the later you have the disease. It's not a uniform mortality rate. So I think that's something which weights getting the disease later compared to sort of getting it earlier. And then the third question is really this question of, I think at a gross level, what you're saying is right. The question is what you do for countries that are not going to get anywhere down to an R0 of 1, just because they have density of populations and so forth. So let's say that actual physical lower bounds, which say the least that they can get to is a 1.5 or a 1.7. Does that change your results in any way? And I'm sure you can't just pull that off the top of your head right now, but I wonder if, because for many developing countries, they've just not managed to knock it down the way that other countries have. Maybe some of it has to do with density, and maybe the mortality rates in the wealthier countries also have to do with the age structure of population, which is also an important determinant of what's going on. Just a few thoughts there, but great stuff.
Simon, do you want to take the question or shall I?
You take the second question. I'll take the first question.
Okay.
Robin and I wonder, it's true, I talked to a lot of Swedes, and I know you talked to a lot of Swedes, but I suspect they are not a random sample of the population. And
I think any Swede that knows you and me is likely to be more non-compliant than the average Swede. So,
but the data I've seen say that care home residents account for nearly half of the deaths linked to COVID-19 in Sweden. So, okay, let's suppose that it is the case that the Swedes were less careful than, for example, the Norwegians. That still doesn't come close to accounting for the fact that the death rate in Sweden was 10 times what it is in Norway. I looked up the average age in those two. Sweden's about twice the size of Norway, but it had 20 times as many cases. And the average age in those two populations is about the same, about 41 years old. Something else is going on, and the Swedish model obviously didn't have the same degree of distancing, it seems to me, that Norway did. So that's my answer to your first question. Dylan can take the second one.
Yeah, I'm actually going to add one extra answer to the first question, which is that I think that while the Swedes did by far the most important things for a super spready virus, like closing large events, the idea that you, for example, could get away with not closing schools or restaurants and bars was really foolhardy on their part. And in particular, the reason they had the care home deaths, I would say, is a very simple principle that I actually first saw articulated by Tim Gowers, the Fields medalist, pure mathematician, who's been one of the few interlopers into epidemiology who has listened and been intellectually modest, and therefore also, despite the fact that as a Fields medalist, he probably has the least reason to be. But he actually was the first person I saw really cogently make this point, and it's a totally obvious point, which is that shielding gets harder the more and more ambient disease prevalence there is, right? So this idea that you can, for example, if Norway has a current prevalence of 5% of the population infected, and Sweden has a current prevalence of 10, Sweden has to be dramatically better in shielding its care homes than Norway in order to achieve the same results in the care homes. And so this idea that you could simply let it propagate in the general population while shielding the most vulnerable ignored the fact that shielding gets harder and harder the more propagation you're allowing in the general population. And I'm still seeing this mistake made. The Brits are making it as we speak with their discussion about reopening schools. Oh, children don't get that sick. And of course, the Brits hating masks, if they do, are reopening schools without masks. But 6 feet apart, because there's a magical wall at 6 feet. You can tell this has made me quite angry. the Brits are not understanding there that, yes, the children themselves will not get that sick. But if the children go home and infect their parents, and then their parents have to go visit grandma, there's a good chance grandma gets sick. And so I think that was the fundamental mistake that the Swedes made, was that shielding, yes, you can distance a bit, but if you don't distance a lot, shielding is going to be extremely difficult. So as far as pushing things into the future, I agree completely with all your points. I think that our model was made with the assumption that all peaks were equally bad, again, simply to be as charitable as possible to the British and Swedish strategies. We were trying, again, to sort of make a steel man and then show that even that steel man could be knocked down. We didn't want to be accused by a passive-aggressive Brit on Twitter of having made a straw man. But indeed, if you add in that extra, all the advantages of the delay, like the fact that healthcare capacity is going to rise, antivirals are going to be introduced, we're going to be that much closer to a vaccine, then you should act earlier and more aggressively than our model says, which just emphasizes, I think, how penny wise and pound foolish this naive optimization in the fear of a second peak was. So I agree completely on that second point. And then as far as what if you can't get the low, that's quite interesting for a couple of reasons. The first is that we did see a preprint by a group in Mexico that was interested in interventions with a maximum possible strictness that tried to sort of adapt our paper to that. Unfortunately, the paper has some math errors, which we've been in touch with them about. But so either they'll fix it or they'll let us fix it, and we'll try to make that extension. But I do think it's an interesting question. The one thing I would say, though, is that I have been struck by how a lot of developing countries have dramatically outperformed the developed world precisely because they didn't try to get too cute and instead just said, look, if this hits us hard, it's going to overwhelm our healthcare system. So we're not going to try to be fancy. We're just going to hit it hard and buy time. And if that doesn't work, it doesn't work, but at least we'll have tried. And Vietnam is a great example of how well that can work. I don't think everyone can be Vietnam, but Uganda's had pretty good results. While, yes, some developing countries, particularly super dense ones like Nigeria and India, have struggled, Mexico has struggled, others have really been, I think, success stories precisely because they took it seriously and did buy time. And eventually they may have a reasonably serious outbreak, but I think by dint of having pushed it into the future, it will be less bad, even if they do have ultimately a reasonably sized peak. So I think that the developing countries that sort of took the act now and figure things out later approach, I think are going to outperform a lot of the developed world, including Sweden, the US, and the UK.
So Chris Barrett is next, and Anil wanted to go next, and then Anil.
Yes, wonderful talk, really, very cool. What I'm interested in is in a larger country, the spatial and temporal spread of the disease across the country begs the question of the locality of the model, right? And where to pick different times and where to do this. And I don't know if it's a question or suggestion, but that would be a really wonderful thing to add. I think that complications associated with describing the epidemic on a nationwide level, associated with the fact that it simply is not as prevalent in some areas as others at a given time, greatly complicates the use of any timing argument. And yeah, so I just thought I would ask if you thought about it and suggest, if you haven't, that might be helpful.
We've thought about it, but it's always good to be pushed to do it because it is an extension that we have thought about doing, and I'm glad it's of interest to people. I think a couple things are of interest there. The US is such an interesting example here, right? Because we've had, I think I can safely say, a disastrous federal response. And I would say it's easy and correct to pick on the administration, but I also think the CDC has been not up to its usual standards. And that has really made the pandemic even more, to quote Ed Yong in The Atlantic, even more of a patchwork pandemic in the US, even more of a meta-population dynamic than it might otherwise have been. The interesting thing about that to me is actually how even with the fact that there are introductions and state-to-state spread, it has been possible for good local policymakers to have a real impact, that the metapopulation dynamics have been almost less important than I might have expected a priori. When you look at how well, for example, the city of San Francisco has done, thanks to London Breed's leadership and her excellent public health team. San Francisco, I think, currently has about 50 deaths from COVID. And the reason is she acted super early and earlier than people thought was necessary. She coordinated extremely well with Gavin Newsom. I think the contrast with the adversarial relationship between de Blasio and Cuomo in New York is interesting, in New York City. But I think a thing that's striking to me about San Francisco's success is that even as the US broadly has failed so dramatically, and even as, speaking of that shielding problem, there have been introductions into San Francisco from places with higher prevalence. The fact that San Francisco took sufficient measures early, built testing capacity, et cetera, has enabled it to remain a little bit of an island, despite the fact that, unlike New Zealand, it isn't one. And given that, I think that is one of the things that gives me hope for the future, is that the metapopulation couplings are not so strong, that places that intelligently leverage distancing, masking, test and trace large event closures may be able to withstand external introductions as long as they are really committed. And that's one of the few things that, at least for the US, does give me hope going forward.
Great. Thanks, Anil.
Yeah, hi. Excellent talk. I really enjoyed it, and especially struck by this importance of the timing. Small point, how robust is that robust timing to other aspects of the model? So, for instance, if people are not strictly removed but can get reinfected, or the asymptomatic part.
So this is another extension that we left off for the moment because, again, we were trying to steel man these potential herd immunity strategies and then show that they still don't work. My intuition, but I would like to formalize this, and this is, we have about 5 extension papers we now have to write, but is one we've talked about is sort of the estimation problem paper, where let's suppose that you're trying to do inference to estimate because of course all these interventions require a knowledge of both the current state of the system and the epidemiological parameters. If you're actually trying to estimate those from noisy data and then intervene, how much worse or mitigated, but I suspect the answer is going to be worse, will these timing problems be? And I think it's a super interesting question. I think it can be handled, maybe not analytically, but certainly computationally. And one thing that is of interest to us here is that I think, at least my intuition, is that this is going to argue even more for slowing things down, because not only does slowing things down buy you more timing robustness by making that exponential less steep, it's also actually much easier to estimate epidemiological parameters for a slower epidemic than a fast one, because you can get more samples before you need to act. And so I'm going to conjecture, though we need to show this, that once you have an estimation problem layered on top of this timing problem, what you're going to want to do is act even more aggressively in the early going, just to allow for learning. And this also connects to some of Ramanand's points, right? That the more you can learn about the pandemic, it's easier to control it, which argues for more slowing things down, just to allow for epidemiological inference and basic science work, so that your ultimate intervention is more robust.
I just want to add a little bit to what Dylan said. Yes, there are a lot of extensions we'd like to make to this. One of them is that taking into account the large number of asymptomatic individuals, I think it's just going to make the points that this paper makes even more dramatic, because the difficulty in estimating where you really are in terms of the epidemic. I'm pretty sure Dylan will agree with that.
Yeah, absolutely.
Great. So, in the interest of keeping this on time, I should thank both Dylan and Simon again. Thank you very much. I think this was a great opening talk, and I think, sets a bar for other speakers. I'm hoping that everyone who is a part of the expeditions team will be able to speak on this forum and contribute to ideas. I think that's the key goal of the NSF project. It gives us really almost a carte blanche in some ways to do good science, and we should take the chance to do it. So thank you very much for doing this. Hopefully, we'll see your paper in print very soon. And looks like you got already a lot of ideas for next papers. I have one general comment to make for the expeditions team. I talked about this to a few people yesterday and here and also at VT. I was thinking, and Simon, your thought is absolutely critical, and I think Rita is also online. I was thinking to try and put up following sort of the thing in mathematics. Take, say, 10 problems that are central to epidemics that are motivated directly from this COVID outbreak and put it as a part of our expeditions. And, we could put it in a paper, but just putting it up would be, I think, an excellent way to energize the community to work on problems that are collectively thought through by this team. Would you or others have a thought on this? Dylan, yourself as well?
I think it's a wonderful idea.
Right. And I think especially the ones like, I don't think we could have thought of having a shutdown like we had now in US. In fact, I remember in February, nobody would want to talk about it, right, Dylan? So some of the problems have come around for this big pandemic. So I think if we write this up well, we would have really created a body or at least start of a area where people can then contribute more and more. So if it's okay with folks, they can send an email to me, but we'll start preparing a manuscript and all of us can contribute to it. And we'll put it out rather soon in a month's time so that, let the world work on these problems.
Great.
Excellent.
Okay. Thank you very much. We'll meet in 2 weeks. Dylan, thanks again for a wonderful talk. It's absolutely beautiful.
Thank you all. This was really fun.
Yeah.
Bye.
Great. Bye.
Thank you.
Bye, everyone.